Hello, I'm Ramaswamy Govindan. I'm a medical oncologist at Washington University School of Medicine in St. Louis. I'm very pleased to talk to you today about lung cancer research. I specialize in treating patients with lung cancer. I also study how the alterations in the genes in the cancer cells cause cancer, makes the cancer grow more, and then find new targets for therapies. So today I thought I'll just talk to you a little bit about how we do this in the research side. And I want to keep this very basic, and I am very happy to be here to present this research that we do for lung cancer. I have no conflicts to disclose. And this is actually you can see a chest X-ray of a patient with lung cancer. And if you notice, this is the heart in the middle, and you can see these white spots on both sides are cancer, lung cancer in this instance. And then after therapy, you can see that you don't have to be a radiologist to appreciate this. The X-ray looks fairly normal. You can see all the white stuff in both sides of the lung gone, and the black, by the way, is air in the lungs, and you can see the normal healthy lungs with all the air here, showing as black on the X-ray. This happened after this patient took a pill form of therapy. And this is very dramatic. You can see a substantial decrease in the size of the cancer burden by taking just a pill. But I would call your attention not to the X-ray, but see the dates here. Basically within 5 days, the cancer regressed after taking the pill. And this happened 23 years ago. And this is around the time I began my research. And this is when I would say the lung cancer research really took off. And the pill here in question was a drug known at that time as gefitinib, widely used in the early stages of clinical trials in lung cancer at that time. And this drug is a drug that inhibits a protein called EGFR, a common protein that is altered in patients with lung cancer that you may be familiar with. Today, we use a third generation drug we called osimertinib or Tagrisso, and gefitinib was the early version or the granddaddy of the EGFR inhibitors. But what is striking here, there are two things I would say: a substantial reduction in the size of the tumor, and more importantly, within a short time. The fact that all these things happened by just taking a pill was unthinkable in the early 2000s. We were used to giving intravenous chemotherapies. Lung cancer was an aggressive cancer. We had limited therapeutic options. And the idea of giving these targeted therapies wasn't there at that time. So this was revolutionary. What seemed like a routine thing now was very uncommon then, but this really set the stage for our targeted therapy approaches. I'll show you a few more examples now that you're an expert on reading X-rays. Here is a patient where you can see substantial loss of air in the lungs with a lot of cancer in both sides, almost filling up the entire lung on the left side, you can see. And then within a few months, you can see lungs becoming completely normal. This happened with a drug called crizotinib that targeted a gene called ALK or a protein called ALK. And now we have better versions of the ALK inhibitors than what we had before. So these two drugs, gefitinib and crizotinib, coming back to back for two different types of lung cancer, was revolutionary in the early 2000s to mid 2000s. Much later, I would say a few years earlier, a few years ago, this is one of our own patients at Washington University, had a big tumor here. You can see a substantial decrease in these things. And this actually was also a remarkable instance. This happened with a drug called sotorasib targeting KRAS, a gene that you know very well is altered in many cancers, also in lung cancer. What is interesting about the KRAS is that we had not considered KRAS to be a target that we can go after. This is so important for the cells, and we couldn't really drug this until recently. So that was a revolutionary step that happened a few years ago. The revolution began with gefitinib and continued with more drugs along the way, and this is one of the latest examples. So all these three instances tell you something unique. If you gave the pathology slides to expert pathologists around the country, they probably won't be able to distinguish one from the other. The EGFR mutated lung cancer from ALK positive lung cancer to the KRAS mutated lung cancer. These are three different genes, three different proteins, and we would not be able to distinguish this by looking at the scans or pathology. You need to map these genes to figure out what's driving them. Remember, 25 years ago, I told you we gave them all chemotherapies, and we didn't really make a distinction. This is EGFR lung cancer, ALK lung cancer, KRAS lung cancer, ROS, or RET. We didn't make the distinction. They all looked similar, almost the same. There are subtle differences, but they're not very reliable under a microscope. But only by doing the gene testing, you can say confidently what is what.